Our first speaker today is Farah Zia. She got her MD at George Washington University. Subsequently, she came to NCI and she was a clinical fellow. And now she's a medical officer in the Division of Cancer Treatment and Diagnosis. And she also sees patients at the CCR in Building 10 with the Women's Malignancies Branch. So her title is Overview of Breast Cancer. Farah.
Thank you, Terry. So let's get started. So I think in order to appreciate how much progress that we've made in breast cancer research and treatment, I think we need to step back and take a look at how things were yesterday. So let's see. In 1975, the incidence rate for female breast cancer in the United States was 105 new cases diagnosed for every 100,000 women in the population. The mortality rate was 31 deaths for every 100,000 women. From 1975 to 1977, of those diagnosed with breast cancer, about 75% survived their disease about 5 years. Among white females, the relative survival rate was 76%, and among African Americans, 62%. In 1975, mastectomy was the only accepted surgical option for the treatment of breast cancer. At that time, only one randomized trial of mammography for breast cancer screening had been completed. Several other trials and the joint NIH, American Cancer Society, breast cancer detection projects were just beginning. The clinical investigation of combination chemotherapy using multiple drugs with different mechanisms of action and of hormonal therapy as post-surgical or adjuvant treatment for breast cancer was in its earliest stages. Then in the mid-1970s, clinical evaluation of the drug tamoxifen as a hormonal treatment of breast cancer was just beginning. In the 1970s, there was no gene associated with an increased risk of breast cancer. So let's look at today. For the years 2009 to 2013, the incidence rate for female breast cancer was 125 new cases diagnosed for every 100,000 women. So that number has gone up. The mortality rate was 21.5 deaths for every 100,000 women, and that number has come down. The 5-year survival rate was 92% for whites and 81.5% for African Americans, and although both numbers have increased, there is a proportional disparity that remains. For the year 2016, it is estimated that there will be 61,000 cases of in situ disease, which is a non-invasive cancer, 246,000 cases of invasive disease, and 40,450 deaths. And all of these statistics are from the SEER program at NCI DCCPS. So fewer than 1 in 6 women diagnosed with breast cancer will die of the disease in the US in 2016. So things to note from these statistics, the breast cancer incidence rate in the US has been steadily increasing since the 1970s, as you can see, which can be attributed to the strong push for screening among women over the age of 40, which is now resulting in better early detection. The breast cancer death or mortality rate in the United States has been declining steadily since 1989, when it peaked at a rate of 33 deaths for every 100,000 women. And the survival rate has been steadily increasing. And that is attributed to both better early detection and better forms of treatment. So let's look at incidence and mortality by race. This is, once again, SEER data. And you will notice that for white females, the incidence has always been higher than African Americans. However, unfortunately, mortality for African Americans has always been higher. And then also, when going back to the incidence, you can see that from the 70s to the mid-80s, there was a steep rise in the incidence, and then it plateaued. And with the mortality, there's now a decline. But again, the disparity exists. So what is breast cancer? It's cancer that forms in the tissues of the breast, usually the ducts and the lobules. It occurs in both men and women, and although male breast cancer is rare, it does occur. This is the structure of the breast. The breast is composed mainly of fatty tissue, which contains a network basically of tiny ducts that connect the glands, the lobules, and the lobes. And about 90% of all breast cancers start in the ducts or the lobes of the breast. And more specifically, it's about 80% in the ducts and about 10% in the lobules. So taking a look at risk factors. So precisely what the reasons are why a woman develops breast cancer are still unknown. We do know, though, that it's a combination of a person's own genetic makeup and environmental and lifestyle factors. Hormones definitely seem to have an important role, and research has shown a link between estrogen levels and the risk of developing breast cancer. Looking more specifically at risk factors, age is definitely a very important risk factor. As you can see, about 80% of breast cancers actually occur in postmenopausal women. Also, women who've had a history of a prior breast cancer, they are at a higher risk of developing another new breast cancer, either in the same breast or in the contralateral breast. Also, women who have a history of hyperplasia, which is not a malignant lesion, but just an excess of cells lining the duct or the lobule, or carcinoma in situ, which is a cancer that remains within the boundaries of the duct itself. So they're at higher risk for actually developing an invasive cancer. And we also know that exposure to excess endogenous or exogenous hormones in the form of early menarche, late menopause, use of hormone replacement therapy, or no pregnancies or age greater than 35 at birth of first child. These are all risk factors. These all cause a woman to have more exposure to estrogen in her lifetime. Also, history of breast biopsies. A lot of women tend to get benign lesions like fibroadenomas, and they'll have multiple biopsies or cysts that are benign. But we do know that women who have multiple biopsies for these benign lesions, they are at higher risk of developing a breast cancer sometime in their lifetime. Women who've had, there's many case reports of this, radiation exposure due to, for example, radiation for something like Hodgkin's lymphoma. There's a lot of case reports of women who will develop breast cancer after that. Also, if on mammogram the doctor tells you you have dense breast tissue, oftentimes that is actually a risk factor we see for breast cancer later in life. Also, sometimes the mammograms are hard to read as well, and things can be missed with the dense breast tissue. Lifestyle factors that include alcohol, lack of exercise, and obesity. They can also be risk factors. Obesity. Women who are obese, they actually have more exposure to estrogen. From the fat, you actually make more estrogen, so that is the reason why that is a risk factor. Okay, so let's look at family history. That's also very important. If your mother, sister, or daughter has developed breast cancer before menopause, you are 3 times more likely to develop the disease. Also, if it's a close relative, such as a cousin, an aunt, or grandmother, then again, you are at increased risk as well. So breast cancer has been linked to mutations in specific genes. BRCA1, that is related to familial breast and ovarian cancer. That's the type that runs in families. We also know that BRCA1 is often associated with more aggressive forms of cancer, such as the triple negative cancers, which are hard to treat and more aggressive. BRCA2 is associated with male and female breast cancer. The P53 and the tumor suppressors genes P53 and RB1 also are a risk factor for breast cancer. P53 is also one of those mutations that will give you a very aggressive type of breast cancer. The triple negatives often have P53 and BRCA1 mutations. And women who have both P53 and BRCA1 together, unfortunately, their lifetime risk of breast cancer is 85%. Then, of course, we have HER2/neu, ERBB2, and c-MYC. These are oncogenes, and once again, mutations are a risk factor for breast cancer. So October is Early Detection Breast Cancer Awareness Month, so I wanted to talk a little bit about early detection. So mammograms. So these are an X-ray picture of your breast. They can be used as screening tools to detect early breast cancer in women experiencing no symptoms whatsoever, but they can also be used to detect and diagnose breast cancer in women who have symptoms. They have a lump or pain or nipple discharge. So it's a very important tool. We know that it reduces mortality by 26% in women aged 50 to 74 and 17% in women 40 to 49. But it has caused a lot of controversy based on different studies. But these are the current guidelines that have been put out by the American Cancer Society. So for women who are at average risk, from age 40 to 44, women have the choice to begin annual mammograms. Risks and benefits should be considered. Well, the reasons all the controversies have erupted, I think a lot of you, especially the females in this audience, probably have kept up with it, but sometimes things are detected that are not really a cancer, and it'll put women through a lot of unnecessary tests and procedures that they may not need. So that is why all of these recommendations have been considered and reconsidered, and these are the current ones. So from age 45 to 54, annual mammograms are definitely recommended by the guidelines. For age 55 and older, the ACS recommends either switching to biannual mammograms, or the patient has a choice to continue annual schedule based on the risks and benefits in a discussion with their physician. So screening should continue as long as a woman is in good health and life expectancy is 10 years or more. So women who are said to be at higher than average risk, the ACS recommends an annual MRI and a mammogram. So who are the women at higher risk? These are women who have a lifetime risk of breast cancer of greater than or equal to 20 to 25% using risk assessment tools that are available based on family history. Usually this history is taken from either your own physician or a geneticist if there's a reason to see one. All right, so also women who have a known BRCA1 or BRCA2 gene mutation, they're increased risk, obviously. If you have a first-degree relative with a BRCA1 or BRCA2 gene mutation, but you have not had testing yourself, again, this is a recommendation for you, or if you've had radiation to the chest between ages 10 to 30. So what about MRI for early detection? So while MRI is more sensitive, meaning it is more often positive in disease, it also has a higher false positive rate. And so this may lead to unnecessary biopsies and other procedures. So that is the reason, again, that it's recommended for some and not for others. The American Cancer Society recommends against the use of MRI for women whose lifetime risk of breast cancer is less than 15%. For women who have a moderately increased lifetime risk of breast cancer, 15 to 20%, we're not really sure. There's not enough evidence to make a recommendation either for or against. So again, that's a decision a patient will make with their physician. But keep in mind, if an MRI is used, it should be used in addition to a mammogram, but not in place of a mammogram. So what about clinical breast exams and self-breast exams? So there is no solid clinical trial evidence that a physical breast exam done either by a healthcare professional or by the women themselves provides any clear benefit in early detection or reducing breast cancer mortality. Due to this lack of evidence, regular clinical breast exams and breast self-exams are not part of the ACS guidelines. However, all women should be familiar with how their breasts look and feel and report any changes to their physician as soon as possible. Therefore, in order to do this, I think all women need to really know how to do a self-breast exam. So it's basically, first you want to look and then you want to feel. So you look, once a month, it's always good to stand in front of a mirror with your shoulders straight, arms on hips, and then with your arms over your head, and you're looking for things like changes in size, shape, color, dimpling or puckering of the breasts, if the nipple is inverted, or if there's any discharge from the nipple. So it's definitely, physicians would still recommend. Just because it's not part of the guidelines doesn't mean you should not be aware of what's going on with your body. And then you want to do the same thing. You want to do it, examine your breast lying down and upright position, but you want to do it rather than looking, you're going to be feeling this time. So you want to use a firm, smooth touch with your fingers flat and together in circular motions. You follow a pattern and you cover the whole breast. It really doesn't matter how you do it. You just want to feel the whole area. So the abnormal signs and symptoms that are need to be observed are change in breast size, pain or tenderness, redness, change in nipple position, scaling around the nipples, sore that's on the breast that does not heal, puckering, dimpling, retraction, nipple discharge, thickening of the skin, any kind of a lump or knot that you feel, or a retracted nipple. So how is breast cancer diagnosed? So a biopsy is necessary to ascertain whether a lesion is either benign or cancerous and involves removing a sample of breast tissue. So there are several methods of breast biopsy, and the most important method, the most appropriate method depends on certain characteristics of the lesion, the size, the location, the appearance. So the easiest is the FNA. That's done when the lesion is palpable and you can feel it, and you just take a fine gauge needle and you withdraw some either fluid or some cells. And if it's fluid, if the fluid is straw colored, usually it's benign. If it's bloody, more than likely it's malignant. The other strategies, the core needle, the vacuum, the ABBI, those are done for non-palpable breast lesions that are deeper in the breast. They're all radiographically assisted, and the only difference is that they're using different kinds of, the tools are a little bit different. Then, of course, you have an open surgical method that's done in the OR. So let's look at the types of breast cancer. A pathologist will review the biopsy to give a final pathological diagnosis. So this slide is just showing you the continuum from normal cells to invasive cells, to invasive cancer, and it's depicting a duct, but it's the similar thing that happens in the lobules. So these are the choices that a pathologist will have to choose from. The normal duct is lined with normal epithelial cells, a single layer. You can have hyperplasia, in which you have too many cells, but the cells are still normal. You can have atypical hyperplasia, in which you have too many cells lining the duct or the lobule, but the cells look atypical, but they're not malignant. Then you can have carcinoma in situ, whether it's ductal or lobular. And that's where there's too many cells, but some of those cells are malignant. Then you can have ductal carcinoma in situ with microinvasion. And as you can see, there are here, there's There's microinvasion of a small area where the malignant cells are going through the basement membrane. And then you have invasive ductal cancer, where you have too many cells that are malignant, and they are coming out of the basement membrane at multiple locations and going into the stroma of the breast tissue. And another thing is inflammatory breast cancer. So it's not completely a pathological diagnosis, though you do have to have a biopsy that will show invasive cancer, but it's more of a clinical diagnosis. But malignant cells here will infiltrate and clog the lymphatic vessels in the skin of the breast. These are the dermal lymphatics. And the blockage in the lymphatic vessels causes red, swollen, and dimpled skin, and that's the classic sign in inflammatory breast cancer. So the guidelines were developed by an international panel of experts, and the minimum criteria for a diagnosis of inflammatory breast cancer includes a biopsy from the affected breast showing invasive carcinoma, and the clinical part of it is a history of rapid onset of erythema, edema, and a peau d'orange appearance, which is the look of an orange peel. And also there's an abnormal warmth to the breast, and you don't necessarily have to feel a lump. These symptoms should be having been occurred less than 6 months. And a very important point is that the erythema it should cover at least a third of the breast. This is an example of inflammatory breast cancer. You see that there's no specific lump, but you see the peau d'orange look to the breast, the orange peel effect that you see. These are other pictures, and you can see how varied these clinical presentations are. It's for this reason that a lot of times, I mean, things like this, sometimes they get mistaken for infection and mastitis, and they get misdiagnosed. And women can go for 6 months on antibiotics thinking that it's like some sort of infection, and when unfortunately it is a breast cancer. So I have seen this happen many times in my career. Here you can see the erythema that's covering the breast. So let's look at staging. Once the diagnosis is established, the physician needs to stage the cancer. Staging is a way of describing a cancer, such as the size of a tumor and if or where it has spread. It is one of the most important tools doctors have to determine a patient's prognosis and determine treatment strategy. Stage 0 is carcinoma in situ, and it's actually pretty curable. Stage 1, you can look at the specifics on your own, but stage 1, stage 2A, stage 2B, and stage 3A are known as early stage breast cancer because they involve the breast and the lymph nodes, but they have not invaded to any other areas as of yet. Stage 3B and 3C are called, it's locally advanced breast cancer because it involves the breast, the lymph nodes, but it has also spread to the chest wall for both of those. And stage 4 is metastatic breast cancer. At this point, it has spread to distant sites in the body, and the more common sites for breast cancer to travel to are the bones, the lungs, the liver, the chest wall, or the brain. So this depicts basically cancer cells escaping into the lymphatics. The malignant cells, once they break through the basement membrane and get through the duct or the lobule wall, they can gain access to the lymph system, and they can travel to other parts of the body and metastasize. And the lymph node is like a filter, and it'll filter out all sorts of things, all foreign particles, including cancer cells. So a lot of the cancer cells will get kind of stuck in the lymph node in their travels to other parts of the body. So the structure of the breast lymph nodes, the ones that are important in breast cancer, we have the supraclavicular nodes, the subclavicular nodes. Then you have your entire axillary chain, and then you have the mediastinal nodes and the internal mammary nodes. And then these are the ones that are important and we're concerned about. So axillary lymph node dissection, it's a traditional procedure for staging breast cancer. It involves removing 10 to 30 lymph nodes in the armpit closest to the tumor. The benefits of an axillary dissection are that all of the lymph nodes can be examined for cancer. Also, it's a reliable determination whether cancer is spreading. But the drawbacks to a full axillary dissection is that there's a lot of post-surgical complications. Patients experience lymphedema, which is swelling of the affected arm on the side of where the nodes have been dissected. Because of the lymphedema, they can have infection, they can have nerve damage from the surgery, from digging out all those lymph nodes that are in there. So they looked for alternatives, and a lot of research was done on that. And so the sentinel node, it is the first node or first few nodes that filter lymphatic fluid drainage away from the breast. If cancer is traveling in the lymph system, the sentinel node or nodes are most likely to contain them. The sentinel node biopsy is a less invasive method to determine if axillary nodes contain cancer with fewer complications. And so based on phase 3 clinical trial data, it is the current recommendation for patients with early stage breast cancer who are clinically by physical exam node negative. During surgery, they inject some dye, the isosulfan blue or technetium-99, and they do this near the tumor or under the nipple, and the tracer in the dye will travel to the lymph node. And the sentinel node or nodes are the first that receive the drainage. So the surgeon will either remove that one node or the cluster of 2 or 3. And if the sentinel nodes are clean, chances are that the other nodes are clean as well. So how do we manage once we get the results? What is the management of a sentinel lymph node? So, well, the easiest, if you have a negative biopsy, which includes a node that shows just isolated tumor cells histologically, 100% complete axillary node dissection is not indicated. But if there are micromets in 1 to 3 sentinel lymph nodes, it's unclear and the decision is individualized. It depends on other clinical parameters that the physician is seeing at the time. If there are greater than 3 pathologically involved nodes, definitively the recommendation is to proceed with an axillary dissection. Inflammatory breast cancer that I just showed you is an absolute contraindication to the sentinel node, and a full axillary dissection is recommended for local control. That is a fairly aggressive cancer. Also, locally advanced breast cancer, again, axillary lymph node dissection is recommended to ensure local control here. And also based on a phase 3 clinical trial by Giuliano et al., I think that was in 2011 or 2012, we know that patients who have early stage breast cancer, who have a negative clinical exam, node exam, but they do have a positive sentinel node biopsy. However, if their treatment plan includes surgery and radiation, we do know that a full axillary node is not, dissection is not necessary. So this is based on phase 3 trial data. So the treatment for breast cancer involves multimodalities. It involves surgery, radiation therapy, chemotherapy, hormone therapy, and targeted therapies. And clinicians have a lot to think about in making the decision. Some of the basic clinical factors that they look at are if the patient is pre or post-menopausal, what stage is the disease at, the histological grade of the tumor, the hormone receptor status, HER2/neu, whether it is amplified or not. And then there are some histological types, actually, that do have a favorable outcome. And these are the mucinous, the medullary, and tubular. And so I didn't talk about that earlier. The most common is the ductal and the lobular. But these are favorable histologies. Also considered in making a treatment decision are the patient's age and general health, and of course, whether or not the patient has any known mutations. So just general treatment steps in early stage disease for both DCIS and early stage invasive breast cancer. Doctors generally recommend surgery to remove the tumor. To ensure that the entire tumor is removed, the surgeon will also remove a small area of tissue around the tumor. So it's like a wide margin dissection. Although surgery aims to remove all of the visible cancer, it is known that many times microscopic cells can be left behind either in the breast or elsewhere. So the next step in the management of early stage breast cancer is to lower the risk of recurrence by trying to eliminate any remaining cancer cells that have been left behind after the surgery. So this is called adjuvant treatment and includes external beam radiation, chemotherapy, hormone therapy, and or targeted therapy. So it lowers the risk of recurrence, but it certainly does not eliminate it, or necessarily does not eliminate it. The stage and molecular features also determine the need for systemic adjuvant chemo and the choice of modalities used. So the selection of therapy is most appropriately based upon knowledge of an individual's patient's risk of tumor recurrence, balanced against the short and long-term risks of adjuvant treatment. Chemotherapy is not without its risks, and so we have to give good thought to who are the patients who need the chemotherapy, and not put patients who don't need it. We don't want to put them under, necessarily, we don't want to give them the toxic chemotherapies. So this approach allows clinicians to determine if the gains anticipated from treatment are reasonable for the situation that they're seeing. The treatment option should be evaluated in terms of both patient and tumor characteristics. So this is just a chart showing some of the chemotherapies that we use in breast cancer in the adjuvant setting or the adjuvant or early stage setting where we are trying to cure the cancer. The most common ones that we use, the ones that have the most effect, are the anthracyclines, which is doxorubicin and epirubicin, the taxanes, which is docetaxel and paclitaxel, and some of these other ones, they're very effective, and 5-FU we used to use a lot in the past. We still do, but some of these other ones we use in the metastatic setting. So with chemotherapy, we know that when we combine chemos together in the adjuvant setting, when we're trying to cure patients, studies have shown us that when we combine and we use polychemotherapy, it definitely gives an absolute risk reduction of relapse and mortality. So in the adjuvant setting, we use combination treatment. We see the most benefit in the group that is in the age group that's less than 50. You can see the graph showing a recurrence and mortality, and there's definitely a bigger gap or benefit in the age less than 50 group as compared to the patients who are 50 to 69. So some of the examples of combination regimens that we use in the adjuvant setting, adriamycin, Cytoxan, followed by paclitaxel. All of these agents can be used in different, there's so many different dosing and schedules. Some of them are given every 3 weeks. Some of them we do dose dense in patients every 2 weeks. In patients who have more aggressive forms of cancer, we want to keep hitting, we don't give them too much time to recover. We give it every 2 weeks, sometimes every 3 weeks. So the dosing and schedule vary, but these are the common regimens. Taxotere, adriamycin, Cytoxan, it's commonly called TAC. Then there's FEC followed by Taxotere, 5-FU, epirubicin, Cytoxan followed by Taxotere, or you can do that with Taxol. These are the common ones. So when patients are hormone receptor positive, we also have the option, or if they're hormone receptor positive, we definitely should use adjuvant hormonal therapy after the chemotherapy. Some of the options we have these days, so there's tamoxifen, and that is, we can give that in pre and post-menopausal patients. It is a selective estrogen receptor modulator. It's a SERM. It acts as an antagonist in the breast and a partial agonist in the endometrium, and that's why it gives women a risk of endometrial cancer. A small risk, not that large. But then there's aromatase inhibitors, anastrozole, or also the brand name Arimidex. This is used in postmenopausal patients. It blocks aromatase enzyme that converts other hormones to estrogen, mostly in the adrenal gland, because that is where most of the estrogen is made in postmenopausal patients. And another AI is letrozole and exemestane. And then we can also suppress estrogen through ovarian suppression using goserelin or leuprolide. So this graph basically shows that tamoxifen definitely gives a benefit to women for recurrence and mortality. And this is 5 years of tamoxifen in hormone receptor positive patients. And for recurrence, you can see that the benefit is mostly seen in the first 5 years. And for mortality, the benefit is seen later. So now we're actually in postmenopausal patients, we will follow tamoxifen with an aromatase inhibitor. And you can see that there definitely is recurrence and survival benefit for that as well. The red line is tamoxifen alone, and the green line is tamoxifen plus an AI. This is recurrence, and this is mortality on this side. So we also have to make choices with targeted therapies, and some of the things that we have to choose from, there's Herceptin or trastuzumab, and that's used in patients who are HER2 positive. It's a humanized monoclonal antibody that binds selectively to the HER2 protein, and it suppresses activity that would lead to cell proliferation. So its activity is on the outside of the cell. Its indication is adjuvant therapy along with chemo in HER2 positive breast cancer, and also neoadjuvant therapy in large HER2 positive cancer, also used in the metastatic HER2 positive breast cancers as well. Pertuzumab is also another example of a targeted therapy. It's a humanized monoclonal antibody that binds to the extracellular domain of HER2. It inhibits ligand-dependent HER2-HER3 dimerization and causes reduced signaling through the PI3K-AKT pathway. And then lapatinib or TiCurb is a tyrosine kinase inhibitor. That's also another targeted therapy. Its indication is for use with Xeloda, another chemotherapy, to treat advanced stage HER2-positive breast cancer that has stopped responding to anthracyclines, taxanes, and Herceptin. More targeted therapies there's an explosion of drugs in this area. Everolimus or Afinitor is an mTOR inhibitor. It blocks energy cells need to grow. Its indication is for hormone receptor-positive breast cancer that has stopped responding to Arimidex and Femara. Palbociclib or Ibrance, it's a cyclin-dependent kinase 4/6 inhibitor. It was given accelerated approval to be used with Femara to treat locally advanced or metastatic breast cancer that is hormone receptor-positive, HER2 negative, and previously untreated with hormones. Then adotrastuzumab emtansine, it's a Herceptin plus emtansine, and it delivers the chemotherapy emtansine to cancer cells in a targeted way. And it's approved to treat HER2-positive metastatic breast cancer previously treated with Herceptin and taxane. So how do clinicians make decisions about which patients to treat with chemotherapy and what to choose? So in the past, I guess we basically used clinical indicators to make our decisions. Those were the parameters of tumor size, molecular subtype, histology, pathological grade, nodal status, hormone receptor expression, the patient's age, comorbidities, and performance status. Well, we still look at these things, but now we are in the genomics era, and we actually use gene expression profiling of the primary tumor to predict response to particular agents. And we also use gene expression profiling of the primary tumor to predict and treat only those patients who are most likely to recur and who will therefore benefit from the addition of chemotherapy. So the study that started all of the interest in breast cancer genomics was the landmark study by Sorley, published in PNAS in 2001. And so basically, they showed that gene expression patterns of breast carcinomas distinguish tumor subclasses with clinical implications. So they defined 6 subtypes, and all of those subtypes had different outcomes and different clinical implications. So they identified the luminal subtypes A, B, and C, and normal breast-like, basal-like, and ERB2 positive. Then they did survival analysis on a subcohort of patients with locally advanced breast cancer who were uniformly treated in a prospective study, and that showed significantly different outcomes for the patients that were belonging to the various subgroups. From these Kaplan-Meier curves that they derived, it shows that luminal A subtype appears to have the best prognosis, and the basal-like has the worst prognosis, right here. So the study by Sorley was groundbreaking, and it set the stage for larger and more elaborate studies in which additional breast tumors would be examined and combined with detailed clinical information. This would provide a means for identifying expression motifs that represent important clinical phenotypes, such as resistance to specific therapies, sensitivity to specific therapies, tumor invasiveness, and metastatic potential. So what are genomic tests? The last decade has witnessed the emergence of genomic profiling of the primary tumor with tests that allow for better risk prognostication and predictive benefit of adjuvant chemotherapy. Genomic tests analyze a sample of a tumor to see how active certain genes are. The activity level of the genes affects the behavior of the cancer and gives information on how likely the cancer is to grow rapidly and metastasize. These tests can be very helpful in clinical decision making. Genomic and genetic testing are very different. Genetic testing is done on a sample of blood, saliva, or other tissue and can detect mutations in genes that are linked to a higher risk of breast cancer. For example, the BRCA1, BRCA2, that is genetic testing. So the MammaPrint 70 gene breast cancer, that is an assay, and it is a tissue-based genomics test which uses microarray technology to analyze a patient's breast tumor biology to predict whether existing cancer has the ability to metastasize. This is an assay that was approved by the FDA in 2007. So the assay itself was approved, however, validation studies in different breast cancer cohorts had to be done subsequently, and there's been a lot of studies. So this 70 gene profile is validated as an independent indicator for breast cancer prognosis in patients that fulfill the following criteria. So patients who are stage 1 or 2, they have invasive carcinoma, their tumor size is less than or equal to 5 centimeters, they are lymph node negative, hormone receptor positive or negative, and HER2 positive or negative. So these are the patients that this assay will apply to. So researchers at the Netherlands Cancer Institute in Amsterdam, they wanted to answer one of the most important clinical questions in breast cancer management. Who is at risk for reoccurrence? I mean, this is the question that we try to answer in making clinical decisions, which patients need chemotherapy. Like I said, in the past, we were using pathological data and clinical data, and now we have genomics. So adjuvant treatment recommendations for chemotherapy are primarily, like I said, based on this question. So the researchers hypothesized breast cancer is a heterogeneous disease. Therefore, gene expression should be different in high-risk breast tumors that may benefit from adjuvant chemo versus those that are low risk and would not likely see any benefit from adjuvant chemo. So for the MammaPrint, tumor specimens from 78 untreated breast cancer patients with known outcomes were analyzed. The entire human genome was interrogated to determine which genes were most predictive of recurrence at 5 years. The 70 most significant genes predictive of recurrence risk were identified, and it's important to note that the MammaPrint interrogates all 7 genomic pathways of the metastatic cascade. So there are genes representing growth and proliferation, angiogenesis, local invasion, intravasation, survival and circulation, extravasation, and adaptation to the microenvironment, and the process starts again. So multiple studies have validated the MammaPrint assay. One of the studies that validated this assay was the TransBig study, and that was published in 2006. They found that MammaPrint can stratify patients into a binary risk classification of either high or low, with a statistically significant difference in the probability of metastasis-free survival at 10 years. So low-risk patients, they have a 10% chance of recurrence at 10 years without any adjuvant treatment. And high-risk patients, they have a 29% chance of recurrence at 10 years without any adjuvant treatment. So this assay is able to divide patients into these 2 groups. So there was a study published in 2010 by Nahr et al., and that also demonstrated the predictive value of MammaPrint for adjuvant chemotherapy in early-stage breast cancer. So those people who had a high risk, they received endocrine and chemotherapy, and they had a 12% absolute benefit. They had an 88% distant disease-free survival. And for the patients who were low risk, they were treated with endocrine therapy alone. And for the ones that were low risk, they also had an arm that they treated with endocrine plus chemo. And when the patients who were treated with endocrine therapy plus chemo in the low risk group, you can see that there was no statistically significant benefit to adding the chemo. So why risk patients the toxicity when you can predict which patients will do better or do fine, just as good with the chemo as without the chemo? So the raster prospective analysis is another key study published in 2013 investigating the use of MammaPrint for adjuvant chemo decisions. 97% of the patients MammaPrint had identified as low risk were disease-free after 5 years. So that's pretty good statistics. 97% MammaPrint says they're low risk and they were still disease-free after 5 years. Also, the study showed that MammaPrint identified 20% more low-risk patients as compared to traditional clinical parameters that we used to use. And as you can see, even though it was identifying 20% more low-risk patients than our traditional, the way we do it, still you had a 97% disease-free after 5 years. The low-risk MammaPrint result was shown to correlate with a good clinical outcome. So this prospective analysis, this is what it showed, and that the high-risk MammaPrint result was shown to correlate with a poorer clinical outcome and a higher response to adjuvant chemotherapy. So an important question in breast cancer treatment is, what is the likelihood of distant recurrence in patients with breast cancer who have no involved lymph nodes and they are hormone receptor positive? So these patients' prognosis is poorly defined by histopathological and clinical measures alone. We're not really sure what to do with these patients. So in order to answer that question, a multi-step approach was used. So now this is the Oncotype DX assay. So a multi-step approach was used to develop a genome assay, and then they had to validate the assay clinically. So RT-PCR method was developed to quantify gene expression with paraffin-embedded tumor tissue. 250 candidate genes were selected from published literature, genomic databases, and experiments based on DNA arrays done on fresh frozen tissue. Data was analyzed from 3 independent clinical studies of breast cancer involving 447 patients to test the relationship between gene expression of the 250 candidate genes and the recurrence of breast cancer. So then they used the results of the 3 studies to select a panel of 16 cancer-related genes and 5 reference genes. And these are the genes that had the best RT-PCR performance and the most robust predictions. And then they designed an algorithm based on the levels of expression of these genes to compute a recurrence score for each tumor sample being tested. So to validate the assay, so that was the assay. Now the assay has to be validated using clinical data. This is how it's done. So they used paraffin-embedded tissue samples from patients who were previously enrolled in the B14 trial. So they're using tumor tissue from patients who that were frozen down from a previous trial. And they used that to validate the ability of the 21-gene RT-PCR assay and the risk score algorithm to quantify the likelihood of distant recurrence in patients who were node negative, hormone receptor positive, early stage breast cancer who had been previously treated with tamoxifen, because this was the cohort from the B14 trial. So, so looking at those patients from the B14 trial, they were able to validate the recurrence score. And so based on that study, they said that the recurrence score has been validated as being able to quantify the likelihood of distant recurrence in this sub-cohort of patients. So the patients who were quantified as high risk, according to the Oncotype DX assay, they had a higher distant recurrence rate at 10 years than the ones who were classified as low risk, according to the risk score. They had a very low recurrence rate at 10 years. These are using data, again, from the B14. So it correlated very well, and they were able to validate that part of the Oncotype DX assay. Okay, so this is also, they were looking at, still these are patients from the B14 trial, and they were looking at the benefit of chemotherapy. So the patients from the B14 trial, those who were categorized as given a risk score in the high risk category of greater than 31, as you can see, they definitely had a very large absolute benefit of chemotherapy. So this one is tamoxifen. The yellow line is tamoxifen alone, and the green line here is tamoxifen plus chemo. And this is years out, and disease-free survival is on this side. And so the ones in the low risk category, they had, as you can see, very minimal benefit from adding the chemotherapy. So this way, we're using the Oncotype DX recurrence score, we're able to predict for certain certain cohorts of patients who is going to benefit and who's not going to benefit from chemotherapy. So again, this is the B14 data. The patients who were characterized as low risk, or the tumor samples with characterized as low risk, they had a risk score less than 18, and their rate of recurrence at 10 years was 6.8%. And you can see it follows perfectly. The intermediate, their rate of distant recurrence at 10 years was 14.3, and the ones who were categorized as high risk, their rate of distant recurrence at 10 years was 30.5%. So the risk score provided by the Oncotype DX assay appears to provide an accurate estimate of the chance of recurrence by risk category. So this test, the Oncotype DX, is both a prognostic and predictive test. It is a prognostic test in that it provides information about how likely or unlikely the breast cancer is to come back. It is also a predictive test in that it predicts the likelihood of benefit from chemo or radiation therapy. This is the feature that makes this test stand out from the others, including the MammaPrint assay. The validation studies have shown that Oncotype DX is useful for both purposes, as a prognostic indicator and as a predictive indicator. And it is the genomic profiling test with the greatest research, and it is the one that is endorsed by the National Comprehensive Cancer Network. So the studies that I was telling you were they were looking at data from B14, but now there are other huge trials that are looking at Oncotype DX prospectively. And the TAILOR-X is actually a huge trial. It's a big deal in cancer treatment areas. And it's the first prospective evaluation of the Oncotype DX. It's a landmark trial. It represents the culmination of a major initiative to integrate molecular diagnostic testing into the clinical decision making. So the primary objectives of the TAILOR-X were to determine whether adjuvant hormonal therapy is not inferior to chemo hormonal therapy in women with a mid-range OncoDX. That's the area that we're not sure. This is the mid-range. We're not sure. The high range, we know. The low range, yeah, that's fine. No chemo. But what to do with the patients in the middle, that's still a question. And so they also wanted to create a tissue specimen bank. And so NCI used Oncotype DX to identify and assign treatment to more than 10,000 breast cancer patients from 1,500 sites in the US, Canada, and Peru. Accrual was completed in October of 2010, and initial results were reported in September 2015, but that was only for one cohort of patients. I'll tell you that in a minute, but the schema was basically, so the patients who had stage 1 or 2 hormone receptor positive, node negative, HER2 negative cancer, they were put into risk categories using the risk score from the Oncotype DX. And those patients who had a risk score of greater than 25, they were given chemo and hormone therapy. Those who had a low risk of less than 10, they were given hormone therapy alone. And then the ones in the middle, they were randomized. Again, we don't know what to do with these patients, so they were randomized to hormone therapy alone versus chemotherapy and hormone therapy. So this is the data that we're anxiously awaiting still. So the key points, TAILOR-X examined whether genes that are frequently associated with recurrence for women with early stage breast cancer can be used to assign patients to the most appropriate and effective treatment and spare the toxicity of chemotherapy for women who would not benefit from it. It was one of the first trials to examine a methodology to personalize cancer treatment. So we only have the results for the low risk cohort, and they're not surprising. The results for the low risk cohort were reported in September of 2015 for women with a recurrence score of less than or equal to 10 who received only hormone therapy. The risk of distant recurrence was only 1% at 5 years. So investigators have concluded that this finding provides evidence that other women in the future may effectively use hormonal therapy alone if the recurrence score from the Oncotype DX is 10 or less. This prospective study supports the clinical validity of the 21 gene assay in identifying patients who may be spared the toxicity of adjuvant chemo. So another prospective analysis for prospective validation, actually, of the Oncotype DX is called it's the Southwest Oncology Group. It's a huge study. It's called the RxPonder trial. This is RX for positive node endocrine responsive breast cancer. This trial opened in January 2011. It's evaluating the use of adjuvant endocrine therapy with or without chemo in patients with hormone receptor positive HER2 negative breast cancer. Specifically, the trial will evaluate women with recurrent scores from the Oncotype DX assay that are less than or equal to 25, that's mid-range, and they also have 1 to 3 positive nodes. So the previous trial, the patients were node negative. This one is looking at node positive, or up to 3 nodes. So the 2 questions this trial is seeking to answer is whether chemotherapy benefits patients with node positive breast cancer who have low to intermediate Oncotype DX breast cancer score results. This trial also seeks to determine whether there is an optimal recurrence score cut point for these patients above which chemotherapy should be recommended. The study is actually open right now. It's open to accrual for a target enrollment of 4,000 women. I just wanted to mention what we have at the NCI as far as molecular analysis for therapy choice. The Division of Cancer Treatment and Diagnosis, we have the NCI MATCH trial. This is a clinical trial that analyzes the patient's tumors to determine whether they contain genetic abnormalities for which a targeted drug exists. That means, do they have actionable mutations? And they are assigning treatments based on the abnormality. So biopsy specimens are sent to one of 4 genetic testing laboratories where they are analyzed for more than 4,000 different variants across 143 genes. A broad-based pre-screening effort is necessary to efficiently identify mutations and assign appropriate therapies. So the trial is designed to add and drop treatments over time. Each treatment will be used in a unique arm of the study. The trial opened for enrollment in August of 2015 with 10 treatment arms. And actually, they enrolled 500 patients in 2 months. And that was like 5 times the expected enrollment. So they had to pause for an interim analysis in November, 2 months after they opened, and then they reopened in May 2016 with 24 treatment arms, with each arm enrolling 35 patients. This is just for you to look at. These are the different arms and the different druggable target mutations. I'm not going to, you can take a look at it. It's in your handout. And then just briefly, the NCI IMPACT trial. It's NCI DCTD launched this trial in January of 2014. The purpose is to assess whether assigning treatment based on specific gene mutations can provide benefit to patients with metastatic solid tumors. During the screening process, samples of tumor from patients with various cancers would be genetically sequenced to look for a total of 391 different mutations in 20 genes. And so what the NCI IMPACT trial does, the design, if mutations of interest are detected, these patients are enrolled in the trial and they're randomly assigned to either the arm that has targeted therapy or the other arm that has non-targeted therapy. And if there is disease progression on the non-targeted arm, then they can cross over to the targeted arm. So what we don't know right now is whether using this approach is really effective at providing clinical benefit. Because clearly most tumors have multiple mutations, and it is often not clear which one to target to achieve maximal benefit. Once a gene is mutated, it can lead to the activation of multiple pathways, resulting in disease progression and potentially requiring several interventions. Therefore, this trial is designed to determine whether people with specific mutations will benefit from a specifically chosen targeted intervention, and if these interventions lead to a better outcome. So the study is currently ongoing. Okay, so just a few slides to end. So what are we going to do in the future? We will use our rapidly increasing knowledge in the fields of cancer genomics and cell biology to develop more effective and less toxic treatments for breast cancer, and continue to improve our ability to identify cancers that are more likely to recur. We will also continue to use and improve this knowledge to tailor breast cancer therapy to the individual patient. This is personalized therapy. Gene expression analysis has led to the identification of 5 subtypes of breast cancer that have distinct biological features, clinical outcomes, and response to chemotherapy. This knowledge can be exploited in the continued development of treatment strategies based on the specific characteristics of each tumor. Furthermore, a patient's response to chemotherapy is also influenced not only by the genetic characteristics of their tumor, but also by inherited variations in genes that affect the body's ability to absorb, metabolize, interact with, and eliminate drugs. So our growing knowledge should enable prediction of tumor responses to individual chemotherapy drugs or classes of drugs, as well as the likelihood of severe adverse events from them. For example, with the hormone receptor, we know that if the estrogen receptor is mutated, we know patients are not going to respond to hormonal therapy. So if we have a genomic analysis that shows a mutated receptor, that might indicate moving on to chemotherapy earlier and not, giving a patient a drug that's not going to work for them. So we will use our increasing knowledge of the immune system to enhance the body's ability to recognize and destroy cancer cells. Breast cancer is one of the major cancer types for which new immune-based cancer treatments are currently in development. So again, the breast cancer of tomorrow, immunotherapy for breast cancer. We have therapeutic vaccines. That's been ongoing for some time, but now we have checkpoint inhibitors and immune modulators. These are target molecules that serve as checks and balances in the regulation of the immune responses. So they kind of wake up the immune system. So it's activating the immune system that's already there to kill the cancer cells. So they do this by blocking inhibitory molecules or alternatively activating stimulatory molecules. Pre-existing immune responses are enhanced, as I said. This is just a list of immune checkpoint inhibitors that are currently in phase 1, 2, or 3 trial, not only for breast cancer, but for other cancers as well. But these are the ones that we are looking at in breast cancer. And we do a lot of this work in the women's malignancies branch. We have the majority of our protocols involve immune checkpoint inhibitors. So we look forward to using advanced technologies, including genomics, to improve our ability to detect breast cancer at its earliest stages when it is most treatable and to better define individual risk for this disease. Finally, we will strive to understand, address, and eliminate factors that contribute to the higher mortality experienced by African American females compared with females of other racial and ethnic groups. That's it. Thank you.
We have time for one question.
We've had good responses, actually. So our trials are currently where they're early, and so we don't have a lot of data yet. A lot of the trials have just opened about a year back, but what we are seeing so far is promising, definitely.
Okay, thank you, Farah.
Thank you.
Have the microphone.
Oh, sure.
You're not leaving with that. Okay. So we have one announcement, that being on Thursday, we do the core visit to the small molecules and the robotics that they use. So for those of you who have signed up for that, I'll be sending you instructions later on this week. And it's going to occur Thursday at 2 o'clock. And our next speaker is Brid Ryan. She is from Ireland. She got her PhD at the University of College Dublin. And then she was accepted into the NCI Cancer Fellowship Prevention Program. And she did her postdoctoral training with Kurt Harris. And now she's an NCI Earl Statman tenure track investigator.
Oh, sorry. First one.
And she's going to talk to us today about cancer health disparities.
Thanks very
Great.
much, Terry. Thank you. Great, thank you. Okay, perfect. Thank you. Thanks very much, Terry. So as Terry mentioned, my name is Breed Ryan. I'm an investigator here at NCI. And a good portion of my research program studies cancer health disparities, and specifically lung cancer health disparities. For that reason, as we go through this presentation, a few of the examples that I give will just by naturally lean towards lung cancer. But a lot of what I'm going to talk about today and the premise behind it applies to many different cancer types. But just if you're wondering why lung cancer is peppered throughout this presentation, that's because it's my laboratory's bias. Okay, so the presentation today is going to have three main sections. We're going to go through a bit of background to cancer health disparities within the United States. Then we're going to talk about disparities in cancer incidence and then also disparities in cancer outcome. And specifically, we're going to try and drill down a little bit into what some of the main causes of these disparities are, because I'm sure as many of you will know, in order to understand and to overcome disparities, you need to first of all recognize them, what they are, and then also try and figure out what actually causes them. I also just, before I go forward, just want to briefly mention, throughout this presentation today, I'm going to talk quite a bit about race, and I use that word quite a bit, but I also just want to outline to a degree the difference between race and ethnicity. Many of you in the room may already know what this is, but I just want to go through it as well for the purposes of clarity. When people normally talk about race, they talk about biological differences between groups that are assumed to have a different biogeographical ancestry or genetic makeup. Now, there is a degree of ethnicity which might also incorporate biology, but it also incorporates other things. It's multidimensional. It's a construct which reflects not just biology, but geographical origins, historical influences, shared customs, shared beliefs, and also traditions that may not always have genetics or ancestry at its common core. Okay. So it's been known now for quite a while. This graph goes from 1975 until 2005, but it has been known for quite a while that there are racial differences in life expectancy in the United States. And this is just one example here. So Black men in general in the United States live about 6.5 years shorter, while Black women live approximately 5 years shorter compared with white women. And that's actually quite a big and significant difference. Now, if you try and look at what are the contributing factors to these differences, cardiovascular disease, without question, is one of the biggest components. But if you look at the second part of the pie chart here, shown in pink, you can see that cancer is another major contributor to these differences in life expectancy within the United States. So the NCI defines cancer health disparities as differences in the incidence, prevalence, mortality, and burden of cancer and related adverse health outcomes that exist among specific populations within the United States. And in addition, we know that African Americans have the highest death rates from all cancer sites combined and from malignancies of the lung, the colon, rectum, breast, prostate, and the cervix of all racial groups in the United States. So this is quite a significant public health problem. Taking here just one example of lung cancer, just to look, just to mention of the presentation today, I will focus specifically on differences between European Americans and African Americans, or Black versus white. But of course, they are just two of the ethnic groups within the United States, and there are many more. 5 of the main groups include Black populations, white populations, Hispanic, Asian Pacific Islanders, or Alaskan Natives. And you can see in this example for lung cancer that historically, going back, and even if you go back even further, back as far as 1972, you can still see these trends. But even though the overall prevalence of lung cancer is declining, proportionally over these years, African Americans still have the highest incidence of lung cancer. It's not just the overall prevalence and incidence of cancer that differs between African Americans and European Americans. What we also see is that for many different types of cancers, the age at which these individuals are diagnosed is also earlier. So it's not just that they're getting more of the very different types of cancer, it's also occurring earlier. And this is a recent paper published by a group actually in DCEG here at NCI, which outlines many of the different cancer types for which African Americans have an earlier age at diagnosis. Now you might ask, what is the driver behind that? Well, there are several different possibilities. One is that the cancer itself might be diagnosed at a younger age in, for example, if cancer is diagnosed in an earlier age, are Kaposi sarcoma, soft tissue sarcomas, and also lung cancer, as I mentioned. But why could this be? One of the possibilities is etiological heterogeneity. So what do I mean by that? Well, it could be that in different populations, the causes of that cancer could be different, or they could in fact cause the cancer at different ages. Another example could be that the exposure that's associated with the cancer, let's just take tobacco as an example, which is infinitely associated with lung cancer. In that example, perhaps the exposure or the timing of the exposure differs between the two populations, and that's certainly a possibility. There could also be differences in the timing and the prevalence and frequency of early cancer detection, which is also very important. And NCI has recognized the importance of this specific question. So why is lung cancer? Why is breast cancer? Why is colon cancer? Why are all these cancers being diagnosed at an earlier age in African Americans? So much so that they have launched the NCI Early Onset Malignancy Initiative. And this has been led by the Center for Cancer Genomics in collaboration with DCP's NCI Community Oncology Research Program. And they have invited 12 different NCORP study sites to participate in this project with the goal of really trying to understand why are these populations being diagnosed earlier. And this is just a recent initiative, so hopefully in the coming years we'll get more information from that. So I talked a little bit about incidence, but I also mentioned that not only is incidence higher in the United States, but the mortality rates are also higher. And this is just another example here of lung cancer. And you can see that for both men and also for women, the incidence the mortality rate is highest in this population compared to all other groups in the United States. And as we go through the talk a little bit later on, we're going to try and drill down into what some of the potential causes and reasons for this could be. As I mentioned a moment ago, African Americans have some of the highest rates of cancer-specific mortality. And I'm just going to show you, this is a nice paper from Cancer about a year or two ago. But what it shows is that and you can see here, yeah, I got the pointer, for African Americans versus European Americans, cancers of the prostate and the breast and the lung and the colon, they have a much higher likelihood to die from their disease compared to European Americans. But you can actually see the opposite trend for Asian populations. These populations are actually significantly less likely to die from their disease, whereas for Hispanic populations, it's a little bit more mixed. And what's interesting to note is that there was a recent JAMA Oncology paper which tried to track these differences and disparities over time to ask the question, are things getting better, are things getting worse, or are things just staying the same? And as you can see from this graph here, this is the likelihood of dying from prostate cancer across different racial groups over time. And you can see that overall, things are getting better. So populations are being treated better, they're being diagnosed better, we have more drugs. So in general, survival is improving, but the disparities are not. So that even though there have been advances in cancer care and cancer treatments, the disparities in outcome exist. So this is a construct which is put together to try and drill down into the multi-layered factors that actually give rise to cancer health disparities, and trying to understand in terms of both an incidence and outcome, what can be done to try and understand them, what can be done to try and overcome them. So I'm going to break it down into two pieces, as I'd mentioned. We're first of all going to talk about some of the differences that exist within incidence, what are the potential causes, what do we know, what don't we know, and then also moving it back then later on the talk to think about mortality and survival and what the various factors are there. So the first thing is to say that obviously we don't know all the answers. The second thing is to say that within an hour, it really isn't possible to go through every single cancer site and every single study. So what I've tried to do is to pull out some common themes about the things that we know and try and frame it within that context. So in terms of incidence, the first thing that we're going to talk a little bit about is geography. So does geography matter? This is a map of the United States, and it shows the incidence of all types of cancer combined. And this is data from the CDC. And the first thing that you can see immediately is that there is some heterogeneity in terms of cancer incidence across the United States. Some of the highest rates of cancer are found in states like Kentucky, Rhode Island, Delaware, Louisiana, and New Jersey, and they're shown here in this dark blue color, where some of the lowest rates are found in New Mexico, Arizona, Wyoming, Alaska, and Virginia. And we're not talking about small differences either. So if you look at this lighter color here, you can see we're talking about between 371 to 431 cases per 100,000, compared to the highest, where it goes up as far as 515. So these are significant differences in the prevalence of cancer across these different states. So geography does matter. Again, taking lung cancer as an example, this is again state-by-state cancer incidence data, and just taking one example of just one state, Nebraska, you can see that for white populations, there is quite a low prevalence of lung cancer and actually very high prevalence for Blacks or African Americans. Now, the reason for this is not known. And the point is to make that while there are differences across the entire country, if you just look at every cancer in every population, if you look at it in a more refined way, you can also see differences by race. So what could contribute to these differences? Well, in terms of geography, it could, of course, be differences in smoking prevalence. The example that I've given here is tobacco. So I'm sure is lung cancer. So I'm sure many of you are thinking, well, maybe the smoking rates differ in each of these states. And of course, that's very true. They do. And you might have noticed on the last slide that one of the highest, Kentucky had one of the highest rates of lung cancer incidence across the US, and that state also has one of the highest smoking prevalence rates also. So there are links like that you can certainly make. But it's also possible that there's other things that could contribute, such as residential migration, racism, advertising, cultural differences, community structure, and social stress. These are all things that could contribute. And in addition to, as I mentioned, just showed here an example of lung cancer, but there are other examples. This is an example, for example, of prostate cancer. And again, you can see the same sort of heterogeneity across the country in terms of incidence. So thinking a little bit more about why geography could be important. Well, on a global scale, and when we think about it, it's very possible that a low socioeconomic status, or SES, that the neighborhoods that have a low SES, for example, could have additional incidence or mortality. So why would that be? Sometimes we know from studies that have been done, there is an unequal burden of pollution within certain low socioeconomic neighborhoods. We know that areas with the highest percentage of African Americans in residence also have the highest exposure to cancer-associated pollutants. And secondhand smoke is also an additional cause of cancer, as many of you will probably know. And disparities in exposure to secondhand smoke could also be a contributing factor. The question has also been asked as to whether or not a deleterious neighborhood effect early in life could affect health outcomes through physiological adaptations to the environment. And this is quite similar to the Barker hypothesis and the idea that somehow in utero exposures or deleterious exposures in utero affect your health later on in life in terms of heart disease and diabetes. What that adaptation could be and how that adaptation occurs isn't entirely known. It is still very much a hypothesis. But there is, of course, the idea that things like epigenetics can play a role. But there is quite a degree of evidence to show that geography is important, but we really don't know yet exactly the very fine details of why it's important. And these are just suggestions and outlines of things that could make a difference. When a lot of people think about geography, one of the first things that comes to mind is, of course, this idea of a rural population versus an urban population. And some studies have been done to try and figure out if there's something about a rural residence which is more likely to give rise to disparities in incidence and outcome. And in fact, there's a study that we just did with the CDC where we looked at disparities in lung cancer incidence between European Americans and African Americans and Hispanic populations. We asked this exact question. We said, we know there are disparities, but are they confined to a specific location? And what we saw was that they weren't. We saw whether you looked at an urban population, a rural population, suburban population, it didn't matter. Disparities existed everywhere. But what we did see is that as you move from a urban location to a more rural location, those disparities increased. So what could it be about a rural population that drives these disparities? Well, there's been some studies that have tried to ask this question and address it. And in some of the cases, they find that populations that live in rural populations are more likely to forego medical care and prescriptions, potentially due to cost. They're more likely to report poor health and health-related unemployment, and also to experience psychosocial distress. And of course, there were other unknown factors that as yet we don't know. But in summary, it does seem that geography, in terms of incidence and mortality, as we'll discuss later, is important. So another possibility that could lead to, or another factor that could contribute to disparities in cancer incidence within the United States includes genetic susceptibility. So what do I mean by this? one of the best examples that we have for this is prostate cancer. Prostate cancer is one of the diseases where there's a very strong difference in incidence when you compare European Americans to African Americans. So much so that African Americans have over twofold greater incidence than European Americans. So what drives it? Well, one of the things that seems to be driving it is this region of the genome called AQ24. Many of you might have heard of this region in terms of other cancers, but there seems to be some variants that map to this specific region that are only found in populations of African descent. So this region, it is associated with prostate cancer risk. And then in addition to that, there are certain regions that are only found, or certain loci that are only found in African Americans. And it's thought that, give or take, that the differences in these regions between European Americans and African Americans actually gives rise to, or explains, about 50% of the increased incidence that we see in African Americans. There's also another region on 17q21, which is thought to explain about 10% of prostate cancer disparities. And there is some evidence for other cancers. I've just mentioned one here, a breast cancer example, 5p15. It certainly doesn't seem to explain as much of the differences as we see in prostate cancer. And then there's a paper from a couple of years ago which looked at recombination hotspots across the genome and asked the question whether or not there was any specific inherited loci that might contribute to increased recombination. Recombination, as many of you will know, is a very frequent event in cancer. And so the question that they were trying to ask is whether or not there was a genetic driver of this that could also be associated with risk. So while that paper did find this region in this gene, this PRDM9 gene, which is associated with higher rates of recombination, it is yet unclear whether or not this specific region and the events that take place as a consequence of it are associated with an increased incidence of cancer. Because, of course, this, as I mentioned here in the slide, this region is specifically enriched in African Americans. But that next step of linking these specific regions with cancer health disparities has yet to be done. Okay, so I mentioned this a little bit earlier, but I want to drill down a little bit into it because tobacco is one of the main etiological agents associated with not just lung cancer, but many types of cancer. So I just want to address it a little bit, if I may. So this is a data that's adapted from a 2006 paper by Chris Hyman and Loic Lamarchand, and it was done in the multi-ethnic cohort study. And what they were trying to do was to look at the relationship between tobacco and lung cancer incidence, because there exists something of a smoking paradox in relation to this. So this shows the lung cancer incidence rates per 100,000 of the population for both men and women in the United States. And what you can see quite clearly is that the incidence in both men and women varies quite a degree across each of the various ethnic groups. And so that should be fairly clear from the graph, in both men and also in women. We know, and it's an undisputed fact, that tobacco is a very significant cause of lung cancer. So when you look at the relationship between smoking and lung cancer in each of these groups, and then the prevalence of smoking in each of these groups, you might expect to see a linear relationship. However, you don't. And what's quite striking, and this is just looking at high intensity smoking prevalence, so these are the highest smokers. And so even though African Americans have the highest incidence of lung cancer, they have amongst the lowest prevalence of high intensity smoking. So that doesn't seem to make a lot of sense. So what else is going on? And this is actually one of the questions that my lab tries to study and try to understand in terms of lung cancer health disparities. So what we do know, and this relates a little bit to earlier when we talked about differences in incidence and whether the timing of the exposure could be different. Well, this is one of those examples. So we know that African Americans tend to start smoking later in life. So the average onset of smoking is 17, almost and a half years for blacks, and it's about age 14.7 for whites, so that is quite different. We also know that African Americans tend to smoke fewer cigarettes per day. The prevalence as adults seems to be similar, but certainly when they're younger, it's lower. And even for never smokers, the disparities in lung cancer incidence persist even among never smokers. So tobacco does not explain all of the disparities that we see in lung cancer. Now, many of you might say, well, maybe the type of cigarette is different. Now, it is, because we know that about 70% of African Americans tend to favor smoking menthol cigarettes compared to about 20 to 30% of European Americans. So you might ask the question, okay, it's not how much these people are smoking. Maybe it's the type of cigarette that they're smoking. And in fact, when you look at that, even though there is this difference, it also doesn't seem to account for the differences in incidents that are observed. So there is yet an unknown, perhaps smoking-related factor that has yet to be discovered that can try and hopefully explain the smoking paradox. And this graph is also, or this image I should say, is also taken from that paper. And it again quite nicely illustrates the paradox that exists in terms of smoking and lung cancer in these populations. So the top panel here is looking just at men. And it's showing that if you just take the reference of the light blue line here for white populations and this dark blue for African American, at this very low intake of just 10 cigarettes a day, there's a very significant disparity in both men and women. Now, it still exists at 30 cigarettes a day, but it is attenuated. And so for some reason, what this particular figure suggests is that at a lower consumption of tobacco, so about 10 cigarettes or less a day, African Americans have a higher incidence of lung cancer for reasons that we just don't understand. And as I mentioned, this is some of the research that my lab is engaging in and trying to figure out. One of the other things I just want to mention at the end of incidence before we go on to mortality is there are many different, so thinking of aspirin, for example, so this may be something that you've come across already in your presentations. The use of aspirin is associated with cancer prevention. Now, another similar type of, well, not similar, but another type of medication that is somehow being repurposed in terms of cancer prevention is metformin. And metformin is one of the most prescribed medications in the United States today. And it was interesting because a recent study of VA, or Veterans Association records, finds that metformin use was associated with reduced risk of prostate cancer. But what was interesting about this study is that they saw the association only within Hispanic men. I just want to highlight that here that's what's highlighted here in the red box. So you can see within African Americans, this was a non-significant reduction, and in non-Hispanic whites, it was the same thing. It was a non-significant reduction. And in fact, when the use of metformin was combined with finasteride, there was even a greater reduction in incidence of prostate cancer. So what this shows as well is that even for these other medications that may be repurposed for reducing cancer incidence or for treating cancer, there seems to be differences by racial and ethnic group, and that may be related to biology and how differences in biology might be manifest in cancers from different populations. And again, this idea of different biology is something that we're going to touch on in a few slides. So coming back to this framework again, we'll drill down a little bit more in terms of in mortality, but a lot of the things that we think about as potential causes, they are multifaceted. So we talked a little bit about tobacco, that's an exposure. We talked about differences in geography, in genetic susceptibility. There's other nutrition can play a role, physical activity, infections, things that we didn't have time to talk about today. The point to make is that when you're trying to think about causes of disparities, you cannot silo the way that you think. You have to think about multiple different factors, multiple different contributing factors, and how they may actually work together. And that's what this diagram on the left tries to get at and tries to drill down on. And that will become a lot clearer when we talk about mortality and survival, because their access to care seems to play a very important role. I'm going to give you a few examples of that. Possibly one of the main reasons that gives rise to many differences in outcome in populations within the United States is the lack of early detection. So every year, many of you will be familiar with the paper that comes out from the American Cancer Society and the CDC, where they talk about the different rates of incidence and mortality across different states in the United States and populations, and they give all the data. And they publish an updated version of this figure pretty much every year. And every year, it pretty much shows the same thing, which is that for most of the major lethal cancers, the stage at which that cancer is diagnosed in Black populations is later than early populations. And as many of you know, and this again bears that out very clearly, the earlier a disease is diagnosed, the better the outcome. So there's a very strong correlation between early diagnosis and prolonged survival. But what we see in many, many different types of cancer is that these tumors are normally diagnosed at a later stage. So if you're trying to think about what some of the drivers for differences in mortality could be, this is certainly one of them to consider. So when we think about why cancers are diagnosed at a later stage, what are the factors that contribute to that? Well, one of them that's often discussed is, of course, access to screening, because one of the best ways to diagnose a cancer early is to avail of screening services. Now, that is to say, not every cancer type has a proven efficacious screening modality in place, but there are some, such as breast cancer and cervical cancer and colorectal cancer, for which there is. So is access to screening a barrier in terms of contributing to cancer health disparities? Well, the evidence would suggest that this is possible for some cancers. Breast cancer mammography screening, a study has shown that its use is similar in an equal access to care setting. Colorectal cancer screening does seem to be lower, however, among African Americans, even within an equal access to care setting. And it's also, there's been a lot of studies showing that uptake of screening for cancers, other cancers such as HPV, may also be lower in minority populations. Now, this is a field that I don't work in, so I'm not doing it justice at all by just giving this one slide over to it. There's a whole very important bolus of work that studies what the barriers to screening are, even in equal access to care settings. And outside of that, what types of interventions can be put in place to encourage the uptake of access to screening modalities. And that is very, very important. But as I mentioned before I went into this slide, while it is possible that access to cancer screening does contribute to some of these disparities in outcomes, it is important to mention that there are other cancers where no validated screening modality exists, where these disparities still exist. So while it is to some degree a contributing factor, that is to say, it is not the only factor that contributes to disparities. So is access to care important? This slide and the next one that comes after it is a study from Cancer Medicine from about 3 years ago now, which, to answer the question, would suggest that yes, access to care is very important. So in this teal color here shows populations who have private medical insurance. The blue line is those that have Medicaid, and the slightly browny orange line are those that are uninsured. And what this picture here is showing, and what these figures are showing, is the outcomes of patients with various different types of cancer. Shown here is non-Hodgkin's lymphoma, prostate cancer, urinary bladder cancer, according to the type of insurance that they had. And the implication here is that the type of insurance, the more insurance that you have, or the better insurance that you have, it is a surrogate for your access to care. And what you're seeing, regardless of cancer type on this slide, and also here on this slide, is that those that have private healthcare insurance have better outcomes. This is a study from 2012, and the example here is given of lung cancer, but it's important to make the point that what I'm going to show you here applies to many different types of cancer. This is a study that was done with a military population, and they all had the same access to care. So they all saw the same doctors, all pretty much at the same intervals, and had the same access to that health care. And when people went back and looked at the survival of those patients within this setting, and asked the question, are there differences in racial outcomes? What they found was that there wasn't, and this was regardless of histology type. And so what this suggests is that access to care is very important, and that if you develop an environment where populations have equal access to care, you can actually get rid of a lot of the disparities in outcome, and that's a very important message. This example, as I said, is from lung cancer, but there are many other examples of this in the literature. This is an example as well of renal cell carcinoma. Again, it's not a carcinoma that I myself am particularly familiar with, but the point again is to make that this was from a military health system, and the graph here would show that there may be, in fact, African Americans may have a slightly better outcome compared to European Americans, but just to make the point that in the paper, once other things were adjusted for, such as race or stage and gender and stage of disease, those differences went away. And they say in the paper that this lack of racial difference in survival in this particular healthcare system may be related to equal access to care. And the important message, as I just said, was that improving access to care is probably one of the single most things that we can do in terms of reducing cancer health disparities in terms of survival. A lot of what I've talked about has focused on how African Americans have a higher incidence of cancer X versus Y, or how this particular population has a worse outcome. But it's important to mention that there are some examples where African American patients have a better outcome, and this is actually one of them. Multiple myeloma is an example of a cancer where there is an increased incidence amongst African Americans, but adverse disparities in outcome are not observed. And this is an example of a paper from Blood a couple of years ago where you can see the Black population is shown in blue here, and you can see that this population actually have a better outcome. And the reasons for this are not understood. It has been suggested that perhaps the type of disease or the form of multiple myeloma that develops in African Americans is perhaps more indolent, but that's just hypothetical, and we really don't know the answer to that. So I talked a little bit about access to care, but what about the uptake of care? Does that difference across populations, and could that make a difference? Well, this is an example from a slide that Anne Geiger had made in a presentation last week, and I saw it and I was actually quite struck by it, because again, we spoke before about geography, and this might actually drill down again to why geography is important. So what this graph shows is the number of oncologists per 100,000 residents by hospital service area. So 0 is shown here in this light yellow color, and more than 7 or 8 is shown in this brown color. So you can see that without question, across the United States, depending on where you live, your access to care in terms of an oncologist can vary quite dramatically. And why is that important? One of the things we're talking in this series of slides about uptake of care. And again, just like there is in terms of outcome in general, there are examples where access to care shows that it is very important. So in this example here of colon cancer, the access to care and the uptake of care amongst the population where there was equally seen was there was no difference. So if you look here at surgery, whether you're African American, European American, there was no significant difference in whether or not you were likely to have surgery, or indeed as to whether or not you were likely to have chemotherapy. But it's important to say that there are examples where there are differences, and lung cancer is one of those. So even if you look at Medicare patients, and this is an example from the American Lung Association's report a number of years ago, they show that African Americans, even in equal access to care, so every patient in the study had Medicare, the patients who were African American were less likely to receive treatment for lung cancer. And this is in terms of both surgery, but also in terms of chemotherapy. And other studies have shown that African American patients with renal cancer are less likely to receive a surgical treatment and more often than likely to die of competing causes. This is a paper or data that I've adapted from a paper from 2013, which shows that in a regular medical setting, so this means one that you or I might visit on a daily or on a regular basis, so it's not a military hospital, it's not an equal access to care sort of setting. But what it has shown that within a regular medical setting, that there are racial disparities in specialist consultation as well as subsequent treatment with multimodality therapies. And this is an example for metastatic colon cancer. So if you're a patient and you walk into a regular hospital, in this example, and you're African American, you are less likely to receive surgery, you are less likely to receive chemotherapy, and you're also less likely to receive radiotherapy. In terms of treatment and your access to the medical professionals, that is also different. In this particular study, they're less likely to receive a surgical consult, a medical oncologist consult, and also a radiation oncology consult. So access to and uptake of care do seem to be important in terms of cancer health disparities in outcome and also in addressing them. So what are the factors that could potentially influence uptake of care? This is a list of several examples. It is not an exhaustive list. And just as I mentioned before, there's a whole other very important set of work, some of which is being conducted by NCI investigators to try and understand what these barriers are. In addition to that, trying to develop interventions to overcome them. Because there are several cancer types for which we do have effective therapies. And sometimes understanding the barriers that exist to getting patients to avail of those various treatments can be also important in contributing to reducing health disparities. We talked a little bit earlier about tobacco in terms of cancer incidence, but what many of you may or may not know is that tobacco is also adversely associated with patient survival. This is true for lung cancer, which you might expect, but it's also true for several other cancer types. And so that is why smoking cessation remains one of the most important public health messages that is out there, because it is so important in terms of reducing both cancer incidence, but also in terms of reducing and improving cancer outcomes. Excuse me. We know from many, many studies that have been conducted for quite a few years now that African Americans remain at high risk for continued smoking. And thus, it is very possible that this is something that contributes to the poor outcomes. So why would this be? Why are African Americans at a higher risk for continued smoking? We know that racial differences exist. So what could they be? Well, we know that some of the factors that contribute to continued smoking include socioeconomic vulnerabilities. These include poverty, stress, secondhand smoke exposure, just like we spoke of earlier. We also know that although the majority of Black smokers express a desire to quit, they're actually less likely to receive and use evidence-based treatments. Black smokers are also less likely to enroll in smoking cessation trials. And we talked earlier about this, the factor of menthol cigarette smoking. So that is certainly something that is different between European American and African American smokers. And there is a hypothesis and some evidence for and against the fact that smoking menthol cigarettes actually makes it harder to quit smoking. So these are all factors that could contribute to African Americans being at higher risk for continued smoking. And that message of smoking cessation applies to every population, of course. But again, there may be a potential to target it to specific populations based on evidence such as this. So we talked a little bit about factors that contribute to racial differences in outcome. We talked about access to screening, access to care, uptake of care, and we talked a little bit about smoking as well. But there are some cancers where, just as we spoke about, even in an equal access to care setting, disparities in outcomes and survival persist. And one of the best examples of this is breast cancer. This is a study shown, this is an old graph, but the point is still the same. And that is, even within an equal access to care setting, African Americans with breast cancer have a poorer outcome. They have a more aggressive disease. And this is interesting data too from a clinical trial, or from clinical trials that was actually published in 2009. And again, this is an example of an equal access to care setting. So every patient in the clinical trial, by the design of the trial, has to pretty much get the same treatment. And they looked in the outcomes of these patients across this particular study. And what they found, just as I'd mentioned, is that for breast cancer, African Americans have a worse outcome, and perhaps maybe for ovarian cancer as well. And for a lot of other cancers, there was no difference. But breast cancer, without question, was one of these more, it seems biologically, it seems to be a more aggressive tumor. Prostate cancer over here at the end in this particular study also stood out. But it's important to mention that some of the evidence for prostate cancer is a little bit dichotomous. So there's some evidence that says that outcomes are the same, and I've referenced some of these papers here. But for prostate cancer, there's also some evidence to suggest that a prostate cancer diagnosed in African Americans is likely to be more aggressive. This is a very, very intense area of research at the moment. There's a lot of investigators trying to figure out if it really is more aggressive, and if so, what are the biological processes that define that aggressiveness? And the same thing is being done in breast cancer, with the reasoning being that if you can define what those aggressive pathways are, it might in itself lend to the design of strategies to try and specifically target that aggressiveness. So as I'd mentioned, while data suggests, and we've gone through a degree of it in the talk earlier, that access to quality care is very important in trying to address cancer health disparities, there is other evidence to suggest that biology, genetics, might also play a role in terms of cancer health disparities, and that's very important. Because if there are differences in the biology, it makes perfect sense logically that there may also be differences in response to therapy. And I saw most of your talk, I didn't see all of it, but one thing that I'm hoping will come from these trials that are all being conducted on Oncotype and MammaPrint, which are really phenomenal advances in terms of precision medicine. Do they predict outcome equally in Hispanic populations, European populations, African American populations. Hopefully they do, and maybe do a job even better, but we don't know the answer to that question yet. And so, sorry if I stole someone's question for later, but it's something that we think about a lot when we're designing these predictive and these prognostic tools. You must also think about their applicability and their usefulness in different populations. And that's something in our lab as well that we certainly take very seriously and think about and incorporate into all of our studies. So biology is important, but why is it important? And what is the evidence that it's important? When we think about biology, we can define it in different ways. We think about genetics. You can think about somatic mutations, copy number analysis, gene expression, methylation profiles, systems biology, inflammation is always important in terms of disparities, and also cell biology. So is there evidence that any of these aspects of biology contribute to cancer health disparities? And without completely, if you've read the slides, you know the answer already. The answer is yes. And I'm going to take you through some of the evidence for that. Coming back to AQ24, so we mentioned this earlier in terms of disparities in prostate cancer incidence for African Americans. And we had mentioned how there were certain alleles within this region which were more common amongst African Americans, and in being more common, it seemed to explain some of the disparities. Well, it also seems that this particular region is associated with higher grade and more aggressive prostate cancers. So we're linking again this AQ24 region not just to higher incidence of prostate cancer in African Americans, but a higher incidence of a more aggressive type of prostate cancer, and that's very important. There's also evidence of a faster disease progression among African Americans in this particular, linked to this particular region as well. So it seems that genetics in terms of inherited susceptibility does seem to be important. There's also evidence for copy number variation, so duplication or amplification events between different populations. This is just one example in African American prostate tumors. It's the IGHG3 region. And the question is currently being asked whether or not this contributes to a higher prevalence and mortality of prostate cancer in African American men. This is not a somatic event, just to make that clear. This particular event is a germline event. And again, there's other studies being done where they're comparing somatic, and this is an example on the right-hand side, somatic events in prostate tumors, and we're doing it in lung, and other people have done it in breast cancer, between different populations. And even just by an eyeball look at this particular graph, what you can see is that across the whole genome, this top line here is, or this bar is African Americans, the bottom here is Caucasian, which we now generally call European Americans. And you can see that there are overlapping commonalities between the two, but there are also very focal specific differences, and these differences will most likely define different biologies, and if we're lucky, guide us to specific different targeted therapies. So there are differences in genetics. Now, many of us are very familiar with somatic genetics, P53 mutations, KRAS mutations. So are there differences in mutations across different types of tumors? Well, this is one example I'm going to give again of prostate cancer, because it's actually one of the best examples that are there. So anybody who works on prostate cancer has probably heard of the TMPRSS-ERG fusion gene. It's a very important fusion gene. But what's very interesting about this fusion gene is that it's one of those genetic events or somatic events which really does seem to differ by genetic ancestry and geographical ancestry as well. And we really don't know why. It's probably related to etiology in some way, but really it's not really known, but it is quite prominent. And if you look at it here, so this is the ERG fusion gene. It's about 43%, occurs at about 43% in European American patients, but really only about 25 to 30% in African Americans. And it's actually even more rare among Asian populations. So it's quite a striking difference for such a very prominent driver fusion gene that we see very strong geographic and racial differences, and we don't really know why. There are other examples. So common PTEN loss is common among European and even European American patients, but it's actually quite rare also among Asian populations and African populations. And again, these are things that we don't know. They're important in terms of etiology because there's often a very strong relationship between the exact mutations that you find in a tumor and the etiological exposures. But of course, in this world and this era of precision medicine and actionable mutations, it's also important to know what the mutations within a tumor are, again, regardless of race, because depending on what mutation you may have, there could be different targeted therapies that are available to you. So again, you should never just pool one particular type of cancer together and assume that as this evidence suggests, that the frequency of those mutations would be the same. Some of you might be very familiar with this as well, and it's, as again was discussed excellently in the talk previously, there are several different molecular subtypes of breast cancer. And so the question is it the same prevalence across different populations? And the answer is clearly no. And what's quite troubling in a way is that that most aggressive form, the basal type, which you spoke about, is much more prevalent in populations of African descent, and then also African Americans here in the United States. Reasons for that are not known, but because it's the most aggressive form of breast cancer for which we really don't have any therapies, this is also a significant disparity which contributes to cancer health disparities in terms of outcome for breast cancer. But when we talk about molecular subtype, even though what I take here on the slide is true, it's also important to point out that the disparities in survival tend to exist regardless of the molecular subtype. So whether it's ER positive, luminal A or luminal B, there does seem to be these differences in outcome, and that's also important to bear in mind. So in terms of cell biology, are there differences? And this is work, only a section of the work that Stefan Alms have done. He's also an investigator in the same lab that I work in. Actually, he works in prostate cancer. And he has shown and this is just one example, as I'd mentioned, is that one of the key differences in biology between a European American prostate tumor and an African American prostate tumor is inflammation. That this is very prominent inflammation signature that you see in tumors from African Americans' prostate cancer. Now, the reason for that is not entirely clear. And his group and other groups are trying to figure out what it is. Some of it could be genetically driven from an inherited perspective, or some of it could actually be also driven by the environment. But there definitely seems to be a very strong inflammation profile that defines a lot of tumors and the aggressiveness of those tumors in African Americans. So speaking of inflammation, this is again one of the things that we study in our lab in terms of lung cancer and how differences in inflammation might drive differences in incidence and outcome. It is one of those processes in the body where there's a lot of historical information describing differences in inflammation between European Americans and African Americans, and even populations of other ancestries around the world. And again, if you just think about evolution itself, it's not entirely surprising that this would be the case. We do know that there is an increase of some autoimmune diseases is higher amongst African Americans. I've given the example here of lupus and TB, but not all. So it's important to things like COPD, which again is very much associated with lung cancer. The prevalence of COPD is actually, if anything, lower amongst African Americans. So the emphasis there is on some autoimmune diseases are higher. There's also evidence to show that levels of IL-6 and indeed CRP, which is a very non-specific inflammatory marker, are higher amongst African Americans. Some of this is driven by differences in allele frequencies in those genes. And we know that if you just take normal populations, or populations without cancer, I should say, and compare their cytokine profiles, some of them are similar, but there are certain cytokines that are different. And if you also then take the cancer populations, like one of the things that we have found is if you take a European American and African American lung cancer patient, their levels of IL-1 beta are the same. But IL-1 beta is only associated with increased risk in African Americans. So that suggests that the biology of that tumor is different and that the IL-1 beta itself is playing an important role that it doesn't seem to be playing in European Americans. Now, that I mentioned a few moments ago as well in terms of prostate cancer, inflammation even in non-cancerous prostate biopsies seems to be a lot more prevalent amongst African American men than European American men. So there are differences in inflammation, and several investigators are trying to understand how those differences actually contribute to health disparities for many different types of cancer. There's also the possibility that different environmental exposures could drive different biological signatures. So this is taking a train of thought in parallel to the idea that an exposure such as smoking might lead to mutation in P53, a hotspot mutation, or how aflatoxin exposure will lead to a very specific P53 mutation in liver cancer. There is this link between exposures with biology that people are trying to track. It's difficult, but there is some evidence that it can occur. And by studying the biology, you're in some instances able to track back to figure out what that etiological exposure might have been. Now, we don't know yet and if or even how much of these exposures can contribute to the biological determinants, but it's really in this era of next generation sequencing in terms of DNA and RNA that we're really being able to ask those questions. But it's important to note that the way we're able to ask those questions is because we take those powerful approaches that include sequencing, but match them and pair them with very detailed patient demographic, lifestyle, exposure data. And it's important to merge the two of those things together to be able to uncover those types of insights. I'm going to share with you one example from Kevin Cullen, who actually shared this example with us at our symposium last week. His area of focus is head and neck cancer, and it's been known for quite a while that patients that have head and neck cancer actually have a worse outcome. African American patients have a worse outcome compared with European American. This was known. But through the research that they did, by again combining this exposure data, this detailed patient data with their clinical data, what they also noticed is that, first of all, head and neck cancers that are HPV positive have a much better outcome. And you can see that shown here. It's very, 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 very different, a very strong difference in outcome. But what they noticed subsequently in their studies was that the prevalence of HPV is actually a lot higher in European American patients. And what they found is that that prevalence of HPV, is what was driving the differences in outcome. And that's actually a very interesting point. So again, it's very important to link various aspects of the etiology and the exposure of the disease with outcome. And by doing that, we can actually learn some very interesting insights in terms of the drivers of biological health disparities. So I'm going to close on just a couple of very, very quick sort of bullet points. I'm not going to go through any of them in particular detail, but they're just points I just want to raise that are also emerging and important points in terms of cancer health disparities. Almost everything that I spoke about in the past 50 minutes or so has spoken about primary cancers. But the incidence of secondary cancers is also higher for the most part in African Americans compared to European Americans. And again, NCI is a leader in terms of cancer survivorship studies. And there's a lot of people who are now trying to look at this in detail to gather more data, but also to try and understand what the factors that contribute to this are. And it's not something, as I mentioned, that I work in, but it's something that's important to be aware of, because thankfully, as more people survive cancer and live with cancer as cancer survivors, this is going to be an important area of study. So we certainly should not forget it. The other thing that I want to mention, going back to the beginning of the talk, I defined ethnicity and race, and that was from a self-reported perspective. But again, because of the power of genomics and because of the power of next generation tools, we're able to define ancestry not just in terms of how you self-identify, but genetically how diverse or homogeneous your DNA might be. This is an example from a paper a couple of years ago in the New England Journal of Medicine, but it just makes the point that while race is important in terms often in terms of trying to understand health disparities in terms of exposures and socioeconomic status and access to care and all those important things, I've also shown you that genetics are also very important in terms of disparities and understanding them. And so for that reason, we often need to understand from a genetic perspective and from an admixture perspective, who is the person that we're looking at. And for this example here, I'll just highlight one person on this graph. So here you have someone who self-reported as Black and had less than 10% African ancestry. And in every study, and we just did a study like this ourselves as well, and the same thing, you will see a small proportion, but a proportion of people who identify as one population, but from an ancestry perspective are different. So that is not to say that you should just look at genetic ancestry or you should just look at self-reported race. The point is to make that you should look at both, because both are going to be important. I also just wanted to, in the same vein, highlight the importance of ancestry in terms of screening. It's been noted that an increased proportion of Native American ancestry is actually associated with an increased risk of childhood ALL. And this has screening implications, of course, but it's also related to treatment, because a very important study from a couple of years ago found that children who had more than 10% African ancestry needed an additional round of chemotherapy in order to respond to treatment. Now, unless you measured ancestry in the way I just described, you would never be able to understand that. And that is one of the reasons, or an example to highlight to you why looking at genetic ancestry, not just terms in African ancestry, but in many different ways, why that's so important. I want to mention screening again in one other point. So I mentioned to you earlier, again, we'll take lung cancer as an example. African Americans are more likely to smoke less. So this is an example of it shown here. Now, very recently, a couple of years ago, NCI did a study where they showed that screening with low-dose CT screening was actually efficacious at reducing mortality from lung cancer by about 20%. This was a groundbreaking study, and it's wonderful. So much so that CMS now reimburses for screening with low-dose CT, but the guidelines are based on age and smoking history. Now, the two things that I mentioned to you earlier is that A, African Americans get cancer at an earlier age, and B, they're less likely to be heavy smokers. And so for that reason, there's a strong likelihood that more African Americans will be excluded from screening programs than European Americans. So what is the potential, consequence of that? Well, it could be an unintended consequence, and that's the widening of disparities. And so for many different, this is just an example of lung, but for many types of cancer where there are known and efficacious screening modalities, people are sitting down to look at it and say, what are the criteria that we are using? And should we really just lump everyone together? In this era of precision medicine and precision prevention, should we really sit down and think about group-specific guidelines? It's an open question. The answer certainly isn't there, but it is an emerging topic at the moment because we're making many strides, but we really want to reduce the potential to widen disparities unintentionally. And the other point is to sort of finish on is we're aware of biological differences between tumors. So I've highlighted some of those for the moment. But the question is, will these differences translate into different responses to targeted therapy? So similar to the point that we're making about the different Oncotype and Mamoprint modalities, we really need to, in the clinical trials, of course, enroll more people into these targeted therapy trials. But to really ask the question, if we know there's differences in biology, can we really expect that using the same drug on a group of different people will have the same outcome? The hypothesis is that there will be different outcomes, but you really can't discern such evidence without a clinical trial. And without clinical trial, you really have to have people enrolled in them. So again, there's a lot of work that's doing to try and increase the representation of minorities within clinical trials, because it's extremely important. And you finished on immunotherapy at the end of your talk. And again, it's the same thing. At the Health Disparities meeting a couple of weeks ago, the same point was made. More needs to be done to include minorities in these immunotherapy trials so that every population can leverage the exciting benefits that are coming downstream for those. And that's a very important point. But it's made within the broader context of understanding that there are differences in biology across these different tumors, and that we need to remain vigilant of that concept as we move forward in this era of targeted therapy. This just basically summarizes what we talked about in terms of some of the reasons for disparities in incidence, some of the reasons for disparities in mortality. It is a multimodal problem. So it isn't just access to care, it isn't just screening, it's not just genetics, it's not just SES, it's all of these things combined, both in terms of incidence and also in terms of mortality. And it really is one of those questions that is a multidisciplinary problem. It's why I love working on it here at the NIH, because we have so many wonderful people here that you can work with, and you don't have to be an expert in one area, because there's people here who are much better experts than I have, or that I am on these areas. So the goal today was a lot of these areas that I've spoken about, I'm not an expert in. The idea was just to kind of give you a flavor of all the different concepts that are important in terms of cancer health disparities. And again, to make the point that a lot of the research that we do tries to understand what causes them, with the idea that knowing what causes them will actually help us to understand and overcome them. So thank you for staying with us. Thank you for your attention. And if you have questions either now or afterwards, please do feel to get in touch. Yes. No problem. Thank you very much.